Well, good morning. It's 7:30. Welcome to this session, a mock trial or deposition after bile duct injury. Thank you for your attendance. I'm Michael Eadie. I'm based in Sydney, Australia, and I'll introduce my co-participants a little bit later. The last couple of years we've seen a spike in interest in bile duct injury during laparoscopic biliary surgery. It started with an editorial spearheaded by George Bursey about 2 years ago in surgical endoscopy, and a lot of interest within the leadership of SAGES, and it's really long overdue when you think about a session which is really devoted by our society to bile duct injury. It's 25 years overdue. These injuries are tragic for patients, and they're really career-defining events for the surgeons concerned. So the purpose of this session is to highlight some of the medico-legal aspects of biliary injury. The legal journey, which takes place years after the event, is an odyssey into the unknown for the surgeon who's good at operating, but not experienced in an adversarial environment designed to trap him or her. And so everyone needs a clear, personal approach to risk management so that we can reduce the profound effect on the surgeon's reputation and livelihood that these sort of events take place. Of course, we can't forget the patient here, but today we're just talking about the adversarial legal environment. We hope that by demonstrating some of these legal challenges, surgeons may change their practice and ultimately reduce the chance of injuring a duct. In deciding upon the format for the session, we chose the deposition, otherwise known as the examination before trial or EBT, because that's what most surgeons are likely to encounter. Many bile duct cases will eventually be settled and not go to trial, but almost all will be subject to an EBT. The plaintiff attorney will gather information, and both attorneys from all sides, from the hospital, from the defence of the plaintiff surgeon, the defendant surgeon and the plaintiff, will be looking for how to size up the defendant and how defensible the case is. The malpractice insurer will be watching carefully for weaknesses in both the case and the defendant, because it won't want to risk an expensive jury verdict. EBT is the fundamental data and performance gathering step in this process. You will be able to get the files as a PDF and a PowerPoint presentation later downloaded from the SAGES website. There will be an audio file from this session that you will have access to as well. I ask you to use your apps to send questions. I'll be moderating the session when we get towards the end of the interrogatories, as they're called, by the participants. Please send your questions along. We hope to have a spirited discussion. As the examination unfolds, I challenge you to identify those elements of this scenario that might apply to you and your practice. Here's hoping we don't see you in court. Our defendant is played by the unreplaceable Dan Deziel. For the past 12 years, Dan reviews most of the files concerning bile duct injury that occur in the state of Illinois. And he has a unique personal experience about the legal aspects of this disaster. John Gould and myself are both practicing surgeons, hopefully with no bile duct injury experience, and nearly a half century of laparoscopic surgery biliary experience. Todd Bartos is a practicing attorney. Todd's from Lancaster, Pennsylvania, and he's been defending doctors to the best of his ability for the past 15 years, and we are extremely grateful for the time he's taken to come down from Northeast to Nashville, Tennessee as our plaintiff attorney. So, if we could have the slides, please. The session will hear evidence from the defendant and with questions from both the plaintiff and the defence attorney. The following facts are not in dispute. We have no disclosures of any significance to this presentation. In 2009, Mrs. Patterson underwent a laparoscopic cholecystectomy following attacks of abdominal pain. Workup had suggested biliary dyskinesia, but no gallstones. At operation, the surgeon, Dr. Sanders, encountered bleeding from the cystic artery, which was stopped with clips. The gallbladder was removed and the patient was discharged home on the same day. Dr. Gordon investigated complaints of pain. Dr. Gordon was the referring gastroenterologist, and the pain occurred in the weekend following the surgery. It was a Friday surgery. Dr. Gordon performed an ERCP the following Tuesday. A stent was placed across a partially occluded bile duct, and the patient subsequently underwent biliary reconstruction with an open hepatocogenostomy some months later. 5 years after the surgery, she's now doing well. The insurer wishes to evaluate whether this claim is defensible, as it has experience with prior cases of ductal injury that went to trial and large judgments were awarded. The surgeon is a locally respected, experienced general surgeon who has never been sued before. Counsellor, please take over your examination.
Thank you. Good morning.
Good morning.
Doctor, and to set up, we're going to jump right into the deposition. We're going to jump around a little bit, and then we'll come back later and talk about some of the points. Doctor, we've established your training, your experience, your credentials, and your background. I want to turn to the events surrounding my client, Mrs. Patterson's surgery. Could you tell us, in your own words, how did she come under your care?
Well, her gastroenterologist, Dr. Gordon, he regularly sends me cases. He had asked me to see her. She had been having abdominal pain. He thought it might be her gallbladder, although he had done an ultrasound that didn't show stones, but he asked if I'd take a look at her.
Okay, and you're sure about that? There were no stones, correct?
Well, the ultrasound she had did not show stones.
Okay, and we'll talk about what you found in the surgery in a moment. Did you perform any investigations yourself after you got that information from Dr. Gordon?
Well, Dr. Gordon, as I said, had already done an ultrasound. He's a gastroenterologist. I'm sure he scoped her too, but he did a CCK HIDA that showed ejection fraction was only 35%. So, you know, we talked with her, and the options were to operate or not and see if she had more pain, and discussed with her the possibility of surgery.
And then you scheduled the surgery, correct?
Yes, we did. That was her choice.
Did you have any discussions, other discussions with her about the surgery?
Well, yes, as is my routine, we would discuss whether she needed an operation or not, what her options were of not operating, and then the risks of surgery. You know, bleeding, infection, and bile duct injury, bile leak, the usual things we would discuss prior to a cholecystectomy.
Doctor, I want to be very clear about something. Are you telling us what you did and spoke to Mrs. Patterson about specifically, or are you now talking about your pattern and practice over the course of your career that you believe you would have done those things?
Well, that's my practice and pattern, so I would have done it with her.
Okay. Doctor, did you make a note?
Actually, I don't think I did the first time I saw her. I was in between cases. I had come down to the ED. She had come back again with pain, so as a courtesy to her and Dr. Gordon, I came down between cases and saw her quickly.
Okay. Doctor, you have the record in front of you. Do you see any note from that night in the ER that you authored?
No.
Okay. Can we agree that you didn't?
Yes,
Okay.
No, yes, I didn't. No, I didn't do a note.
You didn't do a note, okay.
No.
Doctor, can we agree that patient safety is an important consideration for the surgeon?
Yes.
In fact, some would say it's the highest consideration, isn't it?
Well, yes.
Okay. And doctor, one of the ways you can safeguard patients and promote patient safety is to create an accurate record of your thoughts and conversations that you've had with the patient, correct?
Yes.
And one of the reasons you do that is so you personally have a record to refer to later, correct?
Yes.
And another reason is if you operate on this patient and then someone else has to see the patient, as happened in this case, they would have a record that they could look at and know exactly what you were thinking and what you spoke to the patient about, correct?
Yes.
And we don't have that here, do we?
Well, I told you what happened, and it wasn't dangerous to her that I didn't put a note in at that time.
Okay, you didn't follow that safety rule that day, did you?
No, but it wasn't dangerous for her.
I'm sorry, say that again, please?
No, it wasn't dangerous for her that I did not put a note in the record.
It wasn't dangerous for her.
Correct.
Did you tell her you weren't putting a note in the record?
No.
Did you tell her that, although required by law to document all of your interactions with the patient, that you chose not to because you didn't feel it would be dangerous for her?
No.
Okay. Doctor, you felt that surgery was an appropriate and indicated option, correct?
Yes, it was.
Now, her ejection fraction was 35%, wasn't it?
Yes.
Can we agree, doctor, that the guidelines for surgical indication would have a clear path to operation for less than 35%?
Well, I'm not sure there's actually guidelines for ejection fraction as what you need to follow or not. The values vary differently at different institutions. I'm not aware of a specific guideline for the ejection fraction.
Well, doctor, let's talk about your guidelines then, because you practice what you believe to be safe care, correct?
Yes.
35%, where's that fall on the scale for you?
That's the lower limit of normal.
The lower limit of normal, okay. So can we agree, doctor, that you would have to have other indications if it's at the lower limit of normal to push you to the direction of operating?
No, the main indication is pain that's consistent with biliary tract origin, and this is some objective evidence that there's an abnormality that might be correctable with an operation.
Even though there are no stones on ultrasound?
Yes.
Okay. Doctor, let's move a little bit to the surgery itself. Do you remember this surgery?
Yes, somewhat.
Somewhat? Okay. And again, one of the things that you are obligated to do is to create a record of the surgery, correct?
Yes.
And that is an operative note that shows up in the patient's record, correct?
Yes.
All right. Doctor, I want to show you, is this a copy of the operative note from November 13th?
Yes.
Okay. And I'd like to zoom in a little bit, thank you, counselor, to the indications for surgery. What is the preoperative diagnosis?
Symptomatic cholelithiasis is what it says.
Okay, and doctor, for members of the jury who may not know what that term means, what does cholelithiasis mean?
That means stones in the gallbladder.
Okay, now doctor, I'm a little confused. A moment ago you said that the ultrasound, which would have been your only preoperative test that you had available, because you chose not to do any other tests, showed no evidence of stones, correct?
Yes, that's correct.
And yet your operative note, the official record of this surgery, says symptomatic cholelithiasis.
That's what it says, but I can explain that.
Well, I'll give you a chance to explain in a moment, doctor. Is that erroneous?
Yes, that's wrong.
That's wrong.
Yes, you did not have stones.
And the same with the post-operative diagnosis. That's also wrong, isn't it? It says same.
Yes.
She didn't have stones, did she?
No.
And you had the opportunity to look for stones in the gallbladder that you removed, correct?
Yeah, we knew she didn't have stones from the get-go.
Okay, so that part of the record's wrong.
Yes.
All right.
I said I could explain it, though.
Go ahead, doctor, please.
We
Tell
use-
us why the record's wrong.
Oh, we use electronic medical records, and I have templates. Our most common indication is symptomatic cholelithiasis, so that goes to that diagnosis by default. I probably just didn't change it as an oversight, but we knew she didn't have stones.
So you made a mistake.
No, it's just a mistake on the paper. I didn't
Okay.
make a mistake.
Well, that's my point. You were the one who was controlling the mouse, the keyboard, and you chose the wrong thing, or you just went past it and left it at the default.
That's what happened.
Okay. So, doctor, let's talk a little more about the results here. It says HIDA abnormal. Now, a moment ago, you told us it was the low end of normal. So which is it, doctor? Is it the low end of normal or is it abnormal?
Well, it's abnormal for her because she has symptoms.
Abnormal for her.
Yes.
Is there a guidelines out there just for Mrs. Patterson?
No, there are no guidelines about this at all that I know of, as I mentioned.
Doctor, I'd like to now turn your attention to the date of the operation. Can we agree that the date of the operation is 11/13/2010?
Yes.
So November 13th. And at the end of the report, there's something that says date dictated. Do you know what that means, date dictated?
That's when it would have been entered into the electronic record. Yeah.
Is that the date you created the operative note?
This note, yes.
Okay. And that's about a month later, isn't it?
That's what it says.
Well, do you have any reason to dispute that, doctor?
No?
I mean, you trust the computer to get the time right, don't you?
Right. Well, my usual practice is to dictate right after the case. I probably got a notification that the record was missing or something, so I had to redo it sometime afterwards. That happens.
Okay. And doctor, you operated on Friday, November 13th, correct?
Yes.
And yet, we know that Tuesday, Mrs. Patterson was back with pain, with dark urine, and with mild jaundice, being seen emergently 4 days later, post-op day 4, correct?
Well, I think she had been admitted over the weekend. My partner was covering, so Tuesday is when I heard that something was going on, yes.
All right, so your partner didn't have the benefit of the operative note, correct?
I guess not, no.
Okay. And then she eventually had a stent placed, and then 3 months later had the open hepatico-jejunostomy, correct?
Yes.
So by the time that the stent is placed, and you're aware that there was a complication, you were dictating the note weeks after that, correct?
That would be correct. Yes.
All right, so this note was created after you knew there was a complication.
Yes.
Okay. And you say you got a note from the hospital, or you believe you got a note from the hospital. Can we agree, doctor, that based on the hospital's practice and bylaws and guidelines, that you're required to dictate your operative reports within 48 hours?
Yes, I believe that's correct.
And do you know why that is, doctor?
Well, documentation, actually, it's probably mainly for billing, so the hospital can get their proper charges in.
You don't think it could be because that's when your memory of the procedure is going to be the best?
Well, I think that the note at the time, it was dictated as an accurate reflection of the case. So I don't think that was altered.
Symptomatic cholelithiasis is an accurate reflection of the case, doctor?
I already explained that, I thought.
Okay. Can we agree that this is not an accurate reflection of the case in some respects, at least?
Just the diagnosis up top, it's a clerical error. That's all.
Well, it'll be for the jury to decide, doctor. It's also unsigned. You didn't sign this note, did you?
That's my electronic signature, I think.
Well, it says unsigned. So is that a mistake in the computer or a mistake that you made by not signing it?
Well, it says Dr. Sanders there, that's me.
Right? Doesn't say
I don't
authenticated
know what
by,
it
does it?
means, it's in the electronic record. I don't exactly know what it means, but it's an accurate reflection of the operation.
Okay. Doctor, let's move a little forward into the operation itself. If we could take a look, Counselor, at the next section of the note. This is a blow-up of the op report, and during the surgery you stated in your report there was bleeding.
Yes.
And I'd like you to read from the section marked in yellow highlighter.
During this dissection, there was bleeding from the cystic artery that was controlled rapidly with several clips using a 5mm clip applier. Total blood loss was minimal.
Now, doctor, was it bleeding rapidly, or did you control it rapidly?
We controlled it rapidly.
Okay. Blood loss was minimal.
Yes.
Okay. I'd like to also draw your attention. It says hemostasis was satisfactory, excellent. Doctor, which one is it? Was it satisfactory or was it excellent?
Well, they're both fine.
I understand that, doctor, but if I understand your earlier testimony, that's a place where you have to choose in the template what to say.
Right.
And you didn't make a choice there, did you?
Well, either choice is appropriate.
Okay. Well, there's a difference between satisfactory and excellent, isn't there? Otherwise, why would there be a choice between the two?
I don't know.
Okay, fair enough, doctor, fair enough. Now, it says it was controlled with clips, several clips. How many?
Well, I don't recall exactly, maybe 3 or 4, 5, I don't know, a few.
You don't recall?
Not exactly. No.
Doctor, can we agree that when you're applying a clip, that you have an instrument through the port, and that once you get it in the area, the instrument tip where you want it to apply the clip, you then have to pull the instrument and squeeze the instrument to deploy the clip?
Yeah, you have to pull the trigger.
You have to pull the trigger?
Yes.
Like a gun?
Yes.
Okay. Doctor, did you read the radiology report that was done on post-op day 4?
I don't recall.
I'd like to read this to you, doctor. It says, present in the area of the common bile duct are 9 radiopaque objects consistent with clips, some of which appear to overlay the common bile duct and potentially cause some obstruction. Does that refresh your recollection as to whether you ever read that report before sitting here today?
I have no reason to dispute it. I see it.
Okay. So 9 clips is a little different than 3 clips, correct?
I don't recall exactly how many.
And to put 9 clips in there, you have to pull the trigger and shoot the gun 9 times, don't you?
Well, not necessarily. I mean, they don't always come out exactly as you want them. Sometimes we have to, waste a clip or something.
But you don't remember placing 9 clips?
No, I don't. No.
Can we agree that would be an unusually high amount for what you've described as an uncomplicated procedure?
Well, you put on as many as you need to take care of it, and sometimes you need more, sometimes less. Doctor,
you mentioned blood loss was minimal, correct?
Yes.
If we could go to the next piece, please, counsel. Thank you. It says 250 cc's of blood loss. Is that minimal?
Well, it's probably a little more than an average laparoscopic cholecystectomy, but it's,
Well, how much is an average, doctor?
minimal.
100 cc's? 50 cc's?
Probably around there or less.
Okay. 25 to 75, is that a fair range?
Well, sure. I mean, some cases have a little more, some a little less.
Can we agree that 250 is a little more than just a little more than 75?
It's just a little more.
A little more, it's 3 times as much, doctor.
Well, a little more than usual.
Are you sure it wasn't bleeding rapidly, doctor?
No, it was controlled rapidly.
So it was bleeding slowly and got to 250 cc's? Is that your testimony?
My testimony is that we had some bleeding that can occur in any case, and we took care of it in a proper and timely fashion.
And doctor, what about the operative time? 1 hour 59. Is that longer than the usual case?
I mean, the time of a case can vary quite a bit depending upon how hard it is, how quickly things proceed. I mean, that's a little longer than usual, but it's, nothing astronomical.
Okay. And doctor, let's talk about that a moment. 1 hour and 59 minutes is longer than usual. 250 cc's is more bleeding than usual. And you had to put 9 clips in, whereas a moment ago you thought maybe it was 3 or 4 clips, which I assume 3 or 4 would be the usual. So we have 3 things that are higher than usual. Doctor, it's your job in the OR to know when you need to do other tests, when you need to do an intraoperative cholangiogram, when the field is not clean for you to be able to discern the structures. That's your job, isn't it?
Yes, I know when I have to do those and when I don't.
And doctor, you can do a cholangiogram, you can do a test that will show you the biliary tree so that you can know where you need to cut and where you shouldn't cut, correct?
Well, a cholangiogram is done mostly to look for stones. Sometimes we do it to help assess the anatomy if we think something is not quite as it normally is, but usually it's done to look for stones.
But as you get higher in op time, as you get bleeding in the field, those are tests that can help you.
They're not directly related. The use of a cholangiogram is not directly related to bleeding or the operative time.
Can bleeding obscure the field?
Yes?
Can bleeding cause localized swelling that can distort the structures?
No.
No.
No, it doesn't
What about-
cause localized swelling.
What about biliary dyskinesia? Can that cause swelling that can distort the structures?
Not usually.
But it can.
That would be unusual. There's usually not a lot of inflammation there.
Okay. Doctor, were you aware that the more difficult the case, no, scratch that. One last thing you have available to you, doctor, is you could convert to an open, correct?
Well, we could.
Okay, you chose not to in this case, despite the longer op time and the more than normal, 3 times as much, in fact, bleeding, correct?
Yes.
You made that choice?
Yes.
Okay. Doctor, were you aware that when Mrs. Patterson went to the tertiary care center, that she had an angiogram done that showed occlusion of the right hepatic artery?
No.
You weren't aware of that?
No.
And if that was the result of your surgery, that's not a good thing, is it?
No.
Doctor, were you aware that when the expert surgeon, Dr. Harrison, operated on her to repair her injured bile duct, that clips were found at the location of the right hepatic artery?
No.
And doctor, clipping of the right hepatic artery is not a planned part of an operation to remove a gallbladder, is it?
No.
Doctor, let's jump ahead a little bit. If the field's obscured and you can't see, is it possible that you put a clip on something that you didn't mean to?
Excuse me, could I get a drink of water?
Of course, doctor.
I'm sorry, what was the question?
Sure. If the field, let me rephrase it. If the field's obscured and you can't see, is it possible that you would put a clip on something you didn't mean to?
Well, not necessarily. We can suction the blood so we can see what we need to see.
Doctor, can we agree, had you done a cholangiogram before completing the surgery, so before you, even after you clipped, but before you transected, that you would have seen the narrowing of the bile duct and would have known that something, to use your words earlier, was amiss?
Objection. You are asking the witness to speculate. Please mark this objection in the transcript. Dr. Sanders, please answer the question.
Doctor, can you answer the question, please?
Well, I'm not sure I can answer it. I told you, in my view, the bleeding was stopped and there was no indication for a cholangiogram.
Doctor, can you tell me what the critical view is?
Well, that's when you see what you need to see to identify the cystic duct and artery. You usually dissect, around the infundibulum. That's where the gallbladder, or cystic duct, enlarges into the gallbladder, and you sort of separate that from the liver so you can see the duct and the artery properly.
And doctor, the full term is actually critical view of safety, correct?
I think so, yes.
It's to make the procedure safer, correct?
Well, it's to help identify what the structures are.
Well, the word safety's in there. We can agree on that at least, correct, doctor?
Okay.
Okay. You don't mention the critical view in your report, do you?
No.
Why not?
Well, the term is really just terminology. I mean, it's kind of come into the surgical jargon. There are some prominent hepatobiliary surgeons that have used that to discuss in the literature method for identification, but, not everyone believes in it, and every surgeon, has experience. They decide what their own critical view is when you see what you need to see to do it safely.
So you decided what your own personal critical view was before you transected the ducts, or what you thought were the ducts, and the common cystic duct and the cystic artery.
Yeah, I just transected the cystic duct as you're supposed to in the operation. And yes, each surgeon has to make their own determination based on their experience and what's going on at the time. What the proper thing to do is, yes, we decide before we do anything.
Okay. And were you using, you mentioned earlier in your testimony that the laparoscopic system provides a very clear image. Do you remember that testimony, doctor?
Yes, it does.
Did you record the surgery?
No.
Did you take pictures during the surgery?
No.
Why not?
We don't routinely do that.
Well, you're able to do that, correct?
Well, you can. Usually would use pictures or video sometimes for teaching, or sometimes a patient may want a picture of their gallbladder, and you talk about it ahead of time and you get it for them, but there's no provision to do it regularly. There's no real reason for it.
Well, you had a resident in with you that day, correct?
Yes?
So you could have taken a video for teaching purposes, since this was a longer than average time and a greater than normal bleeding. So there might have been some teaching value to that resident or the other residents, correct?
Well, the resident was there, so they didn't need to see a video.
What about the other residents, doctor?
Well, there's no special value to me videotaping every case to show it to all the other residents.
Okay. Doctor, you testified earlier that Mrs. Patterson was sent home the same day of surgery.
Yes.
Given that there had been considerable bleeding during the surgery, wasn't it reckless to send her home?
Absolutely not.
Why not?
She was perfectly stable. I mean, she was not bleeding. Her hematocrit was 33, 34. She was eating. Her pain was controlled. She was perfectly fine to go home.
Doctor, you could have kept her there if you felt there was a need, correct?
Yes, if we felt there was a need, certainly.
Okay, and the reason you didn't feel there was a need was why? Because The
There was no clinical
bleeding
indication.
wasn't 4 times normal, the op time didn't go over 2 hours. What's the reason?
It's got nothing to do with that. She was doing fine. I told you she was eating, her pain was controlled, she was no longer bleeding, she showed no sign of any problem, and she was perfectly fit to go home.
Did you give her a choice, doctor? Did you ask her if she felt good enough to go home? Or did you tell her it was time to go home?
No, I mean, she was fine to go home. I may or may not have asked her, but, you know, there are financial problems too. I mean, you can't keep somebody in a hospital if they don't need it medically for acute care. Their health plan's not going to pay for them, and then, you know, they have that extra burden as well.
Well, doctor, let's be very clear. You're in charge of the patient, not the health insurer, correct?
That's right.
And so if you believe there's a reason, regardless of whether the health insurance is going to pay for it, it's your job to keep that patient in the hospital, isn't it?
If the patient needs to be in the hospital, she did not.
Okay. Now, I wasn't asking about this particular patient. I'm talking more generally, doctor. It's your job to be the patient's advocate for safety and for care, regardless of what the insurance company says, correct?
Yes, but we also have to consider the financial implications on our patient's behalf.
Doctor, turning to the events that occurred after my client's discharge, when did you first learn she wasn't doing well?
Well, I think we discussed that. It was Tuesday, and I was in the OR, and I got a call from Dr. Gordon, and he was doing an ERCP.
Okay. Doctor, so you were already in the hospital. Dr. Gordon then contacted you.
Yeah, I was at another hospital at the time that morning.
Okay. And according to the records, which Dr. Gordon dictated the same day that he saw your patient, the indications were abdominal pain and some jaundice, correct?
Yes, she was admitted over the weekend when my partner was covering, and the first I heard was Tuesday morning when I got the call in the operating room.
Okay, and what did you learn about the status of her bile duct?
Well, he was doing an ERCP, and he thought that there was some narrowing and some stricturing in the middle portion of the duct, so we discussed what to do about that.
Okay. Dr. Gordon has already been deposed in this case, has testified that the two of you had a discussion about referring the patient to Dr. Harrison that day, you know, rather than putting a stent in. Do you recall that conversation, doctor?
Vaguely, but she didn't have to be referred to the tertiary center right away. She was stable. She had some narrowing. She wasn't septic or unstable, anything like that. She just, you know, the stent was the initial management of this, and for many patients it would be the definitive management.
Okay. Not for her, though, correct?
Well, as it turned out, no, but most of the time the stent can adequately take care of this. And again, I was in the operating room. I hadn't seen the pictures yet, so I don't know exactly how tight it was, but this was an appropriate thing to make sure she was stable, to alleviate whatever obstructions she had, and then we can see how she does and sort things out. If she needed a referral after that, that could easily be arranged.
And you didn't look at the ERCP, did you? You relied on Dr. Gordon to tell you about the ERCP, correct?
Well, he was doing it at the time, and I was doing something at the time.
Okay. And before you made that decision, you could have gone to look at some of the films from that procedure, correct?
Well, I did see him later.
Okay. And doctor, had you referred the patient more promptly to the specialist center, to Dr. Harrison, don't you agree that consideration might have been given to reoperating at that time?
No, I don't think so.
And doing a more definitive repair, and possibly even avoiding the later hepaticojejunostomy?
No, I don't think so. I mean, the initial management of this was the stent, just like she had. There would be no reason to operate on her sooner. And in fact, I mean, this is the first duct injury I've had, and I don't, you know, do these repairs myself, but my understanding is that when the experts see these patients, they want full characterization of the anatomy proximal to the injury before they operate, so there would be no reason to urgently intervene for her. That would not be in her best interest.
And you made that decision for her, what would be in her best interest?
Yes, her best interest was the stent at the time.
Doctor, did it meet the standard of care to delay the operative note for 4 weeks?
I did not violate the standard of care in anything I did with her.
Well, doctor, you like to practice in a safe manner. That's your testimony here today, and you've made that very clear that that's your goal when you practice, correct?
Yes.
And your practice is also to dictate contemporaneously because that's your practice and also because it's safe for the patient, correct?
Yes.
And doctor, the operative report in this case has mistakes in it, and those mistakes were made after you already learned there was a complication, correct?
Yes.
Did it meet the standard of care, doctor, to send the patient to the PACU and discharge her to home after a 2-hour operative time, 250 cc's of bleeding, and pulling the trigger 9 times to deploy clips?
Yes, absolutely. I think we've discussed this.
And it's your testimony here today under oath and before the jury when they look at this video, when we go to trial, that all of those together met the standard of care. That's your testimony, doctor?
Yes.
Doctor, I have no further questions.
So in this process, the defense counsel will now redirect some questions to the defendant. Counselor?
Thank you. Dr. Sanders, as your defense attorney, I have a few questions that I think will help clarify some of the answers that we just gave to the preceding questions. You stated that Mrs. Patterson...
To your wind-up here, could we get to the questions, please?
You bet. You stated that Mrs. Patterson was very insistent that her gallbladder be removed. Can you expand on that answer?
Yes, she was having recurrent bouts of significant pain. She had 2 young kids. I mean, she had been to the emergency department a couple of times with this, and clearly she wanted something to be done if it could be, and she had the appropriate indications, an abnormality, and we could potentially alleviate her symptoms with an operation. So that's how we proceeded to help her.
And you testified that you told her success in this situation is not guaranteed. Is that correct as well?
Yes, especially since she didn't have stones. I mean, it would make that quite clear to her. Her chance of being alleviated of her symptoms is much better if she had stones than if she didn't, but there's clearly some chance, and a reasonable chance, she's going to be better with an operation, with her abnormality, even without stones.
And you had a detailed discussion with her about the possibility of injury to the bile duct as well.
Absolutely. We talk about a whole litany of complications: bleeding, infection, blood clots, bile leak, dropping stones, and duct injury. That's standard with any gallbladder operation we do.
You also testified that including gallstones in the indication for surgery when in fact there were none was really more of a clerical error. And your letter to Dr. Gordon clearly stated that biliary dyskinesia was the indication for surgery. Is that correct?
Yes, my letter to the referring physician clearly said it was dyskinesia.
Did the time you dictated the operative note in any way affect your care of this patient?
No.
You were asked why you did not convert after the bleeding event. Would you explain for the record your reasons?
Well, managing bleeding is something we're trained to do. It's a routine part of an operation, and bleeding occurs. We take care of it properly. There's nothing unusual about that. It's part and parcel of being a surgeon and our everyday practice. We know how to do it safely and well.
And you did not perform a cholangiogram in this case. Is selective cholangiography an acceptable strategy amongst your peers in laparoscopic cholecystectomy?
Yes, absolutely.
The expert witness for the plaintiff has testified that the standard of care dictates that a cholangiogram be done in all cases. And let me read from his testimony. The indication for cholangiography is cholecystectomy, period. Do you agree with that statement?
No, I don't, and nor do most surgeons. Most cholecystectomies, in fact, are done without cholangiograms in this country. Either selective or routine cholangiography or no cholangiography can be appropriate.
And regarding photo and video documentation of the surgical procedures, you testified that this is not your routine. Is that correct?
That is correct, yes.
And are you aware of any specialty surgical society guidelines or regulatory requirements that the image or video documentation be conducted of surgical procedures?
No, we usually use these, as I mentioned, for teaching or sometimes for the patient's benefit if they'd like it. But no, I don't know of any requirements for documentation. Video.
Was Mrs. Patterson medically fit for discharge when she went home after your operation?
Yes, she certainly was. She was looking well. She was eating. Her vitals were stable. Her crit was stable. Her pain was controlled. She was fine to go home.
And doctor, you've been practicing in this city for quite a long time. Have you ever had another patient with a bile duct problem after a laparoscopic gallbladder procedure?
No, fortunately not, and I feel badly about this one.
And can problems with bile duct narrowing, excuse me, ever occur after gallbladder operations with or without the bile duct being directly injured?
Yes, it can. Sometimes just in a difficult case, as a result of inflammation, a patient can develop a stricture.
Thank you, Doctor. I have no further questions.
Thanks, Councillor. Todd Bardos is going to return to the podium just to sum up and talk a little bit about some of the legal issues that we've encountered today, and then we'll open it for discussion. I remind you that please use your apps to send any questions. I do have a question here concerning a state in the US, which I can't understand. If the sender could resend it, please.
Good morning, thank you. So what can we learn from depositions? As we heard earlier, the deposition or the EBT is really the first and sometimes last chance for the surgeon to explain his or her care. And what we tried to do in this setup this morning is take everything that we've learned both from being expert witnesses and from being involved in the litigation process, and for myself being involved with defending these types of cases, and really tried to distill it into a real-world scenario. And so we actually lifted liberally from some cases for this. And what we're trying to illustrate, and what we hope, and let's see if I can get this to work, there we go, is it all comes down to preparation. It's like when you're getting ready for a difficult case. It's about the facts, it's about focus, and it's really about strategy. So with a deposition, it starts when the complaint is filed. When the complaint's filed, and they're getting worse and worse now in what they say, the job of the plaintiff's lawyer is to frighten you, frighten your insurer, and get you to a point where you're sitting in a deposition and you're not talking about the medicine. I mean, I think that Dan did a very good job when he was talking about the surgery and the medicine of explaining it. My job, playing the role of plaintiff's lawyer, was to make him look not credible on the peripheral issues, the documentation, the communication with the patient, the lack of recollection, the 1 month until the op note was prepared. I mean, if this went to trial, the plaintiff's lawyer would have opened with talking about that note, that this was a note that was dictated 3 weeks after the complication was known. And the goal is to get the jury looking at the defendant doctor as someone who's not credible on the basics and therefore not credible on the medicine. So if you're not credible on the documentation, you don't have a good relationship with the patient, you may know your medicine really well, even if it's just from your standard practice. But they will use that to chip away at your credibility in front of the jury, because the jury, they're all patients. They've all been through the system, they've had people through the system, enough gallbladder procedures are done in the country that people on the jury are going to know what one is. And the real unfair part of the litigation process is the jury already knows the outcome. They know there's been an injury. So they're looking for that moment. They already know how the story ends. They don't see it unfolding in real time as you did. And that's a problem with the adversarial process. And so the best thing we can do is we go back to documentation. What do your forms look like? What's your conversation? If you rely on a guideline, document it. If there's a guideline that's applicable and you deviate from it, you can document that as well. Documentation is the cornerstone of everything that comes down in the medical legal system. I know we've been talking about documentation. Probably every risk management lecture you've been to has touched on documentation. In the world of EMR, it's getting more difficult, not easier. Templates, which are great for billing, are really not great at providing the most useful information at the right time to the right people. But documentation, discussions, again, anything you talk about with the patient, if you can have a way to prove what you said to the patient that's different from just, oh, that's my normal practice. Because in this scenario, Mrs. Patterson was going to come in and testify that she didn't remember any of those discussions, that she was nervous about the surgery and felt that the doctor was pushing it on her. Well, now you have a he said, she said, you have the injured person, and now you have the doctor who I've chipped away at the credibility on issues that are peripheral to the actual procedure. And so in your deposition, in your cases, what I would encourage you to do, hopefully you never get, I always say having a good lawyer in your corner is like having a nuclear missile in the silo. You want to have the biggest, strongest one available and hope you never have to push the button. But what's important is when you have a litigation, when there's an issue, you need to be working closely with your attorney from the beginning. And if your attorney's not doing that, if you can't get a hold of him or her, talk to your risk manager if you're employed in a hospital system. Talk to your carrier, talk to your personal counsel, and get them to push the way it should be. Because sometimes, again, you're assigned the lawyer, you don't always get a choice, but you have a choice on how much you push. And this is very personal. I've never met any of my clients over the years, they've never said, yeah, I got up that morning and I knew I was going to commit malpractice. Yeah, it's fine. It's devastating. Every complication is devastating. The process is devastating. So again, for depositions, have you talk to your lawyer, and has your lawyer talked to an expert? Not someone down the hall, not someone they know. Have they actually talked to a for-real expert who's going to come into court and who's going to put their hand, and swear on the Bible and say, this would met the standard of care and here's why? Because that's important. What I'm doing in my questioning is I'm layering in facts that my expert, as the plaintiff, is going to use to just destroy the defense doctor. On the defense side, I use the deposition to layer in the facts that my expert, representing the doctor, will be able to use, and that the plaintiff's expert's going to have to either ignore or minimize in a way that ruins their credibility. So getting the expert involved from the beginning, if you deviate from the guidelines, document it, because that'll allow your expert to really support your care if there's a legitimate, valid reason. And finally, I'm going to touch on this, although this will be available online, and certainly if anyone has questions that we can't address today, I encourage you to talk to me. The deposition of today is not a Q&A session. The days of the screaming and the bombastic and over the top are largely over. As the plaintiff's lawyer, what I'm doing is very methodically piecing through it, getting him to react, because I'm videotaping him. I'm getting him to react. I want those reactions, because then I get to play this at trial. And on a screen like that, I get to play in front of the jury when the doctor says, I didn't know that. So it's not the polished, confident defendant in the courtroom, it's the nervous deponent that the jury will see. And so I prep all of my witnesses on video, I grill them. And I ask them the uncomfortable questions. And we look at the reactions. And it's a sobering moment, but an important one. So again, do you have the right people helping you through the process? And so again, documentation, the facts, and what it comes down to now with bile duct injury, since they know the outcome, the jury knows the outcome, it's a series of little things pieced together that make it look like someone did something wrong. Because again, court is not about the truth, it's about the perception of truth. And that's a very important difference. And so my goal was little by little, as Ed Vesters talked about yesterday, it's not one big thing that goes wrong, it's a series of little things that add up. So again, thank you for your time, and I don't know if we're going to go to questions
Absolutely.
now, but
Yeah.
thank you.
So in the limited time we had available, I hope you've seen some of the traps, pitfalls, and ways to work yourself through this process. This is a short exposure, a very rapid course, but I think in this short time we've concentrated some of the major issues. So we'll take questions from the floor, and I have a series of questions that have come in online. In the middle, Mike.
That was great. A couple of questions. So first, like in this case, the
Could you introduce yourself, please?
Yes,
and where you're from?
Richard Puri, Waycross, Georgia. So like in this case, the surgery was done on Friday, and the note, didn't get dictated, but it's very common that when you do Friday surgeries, the note may not be dictated for a couple of days, even though you've done it the same day. So how does that play into all of this? The second question is that if you see a patient, let's say, the week and you operate the week after, you have a fair recollection of maybe the discussions you had. But gallbladder being as common as it is, we all see a fair bunch of gallbladder patients. And if the surgery, let's say, is scheduled for a month or 2 months because of a busy schedule, while you have the same discussion and we discuss the same things, you may not obviously recollect the very words you said, or so you're assuming that yes, you did discuss the risks and benefits. And last question is that probably once a year or maybe a little more frequently, you see patients who actually have acalculous cholecystitis. So they don't have gallstones, they don't have biliary dyskinesia, but they have the right story. And while you have informed discussion that, look, I mean, you may not benefit, then there's potential consequences. Well, should we not be operating on these patients because, well, we might injure the common bile duct?
So we've got quite a few questions there. Maybe I'll ask the clinicians involved. Dan?
Well, just dictate your notes as soon as you can, right after the case. I mean, it doesn't matter if they don't transcribe them or enter them somehow for a couple days, but your duty in all of your medical record documentation is just to do it almost contemporaneously. That's what's going to help you the best. If something goes wrong with the system and you've done that, the burden is off your shoulders. The risk and benefits, document. And I tell you what, I would be as specific as you can. List a litany of things that you discuss with the patient and others. Leave it open, but your documentation of the informed consent is critical. We didn't get into an informed consent issue here too much, but that often plays an important role. As far as the indications for surgery and biliary dyskinesia, I think that's a different discussion, but clearly there are non-calculous conditions of the gallbladder that warrant cholecystectomy.
We've got quite a lot of questions online, and some of them are very interesting. I don't want to hold the discussion from the floor, but we'll try to alternate them. One of the questions online was, if you dictate the critical view is obtained, and since, if done correctly, this prevents duct injury, can this be used against you to suggest the surgeon was incompetent in doing critical view if the duct is still injured? Todd?
Well, it's an interesting question, and one of the things we saw yesterday, for those who were in the panel discussion from 3 to 5 next door on bile duct injury, is simply stating that you were able to visualize, or that you were able to get a critical view, that there are still some situations where, although it's dictated, it wasn't done. And so dictating it is one thing, doing it is another, and being able to describe what you mean by it. One of the things that we talked about in our conference calls leading up to today is that there's a wide variety of what critical view means to different surgeons. And so if you have a specific way that you use it and have defined it, then you need to be ready to explain that. It's not a get out of jail free card. Mistakes can still happen. Again, I don't think anything is 100% other than just not doing the procedure. But if you are able to not only expose the critical view, if you are now going to taking doublets and going down that road, again, it's about building the record for you that will allow you and your attorney and your expert to say, this is the reason why this happened. It had nothing to do with misidentification, or it wasn't a misidentification outside the standard.
One of the features of a successfully defended case is an operative report that supports your decision-making and supports how you decided that this was the cystic duct, this was the cystic artery. Describe what you did. The term critical view in your operative report is prevalent now, but it's a trap also. And here's why it's a trap. Because when the doctor is deposed, the doctor cannot explain correctly what the critical view is as it's described. The plaintiff's expert typically cannot describe it. And unfortunately, often the defense expert cannot correctly describe it. So document how you decided in your operation that you decided that this is what it is, and whether you use the critical view word or not, that's up to you. But it's not going to be, as was termed, a get out of jail free card.
The rear microphone.
Harry Anderson from St. Joseph Mercy, Ann Arbor. So about 20 years ago, I gave up having the residents dictate my operative notes. Is there maybe a recommendation as to whether the resident should dictate or whether the attending should just dictate and be done with it?
I think there's a dual role here. I work in Australia. We've just introduced an electronic medical record into our system. believe it or not, directly from a handwritten operative report. I was astounded after 25 years that in my system they were still handwriting operative reports, and this is generally delegated to the residents. I think there are two issues here. There's the issue of accurate description of what goes on, and then coverage of the legal aspects as well. And so it's an educational process. If the residents don't perform or prepare the operative reports, that's a really important part of their learning about how the surgery takes place. I think probably in the early days you can get them to prepare operative reports, you vet them carefully, and you have the inclusions in them which you think are important. You have these buzz phrases and adequately described. I think most operative reports are probably too brief for my liking, and with word processing and that sort of thing these days, it's very easy to give a very complete operative report. Middle microphone.
Joe Dodd, Nevada, Missouri. Back in the early days when Doug Olson was looking at the bile duct injuries and suggested the various maneuvers to prevent them, I'd adopted the term using a modified retrograde dissection to get there. And I still dictate that, and now I add the critical view of surgery, of safety. But it sure seems that one of the big problems is these templates. I could imagine that could get to be a very hard thing to defend because it's just like a stamp. There's nothing specific. I realize that the templates allow, or supposedly allows, some tweaking, but I wonder in reality who really does that. And
well, as
it can make you look like an idiot when you're in the hot seat.
As you've correctly identified, we included this deliberately to highlight this issue. We included the issues of photo and video documentation to touch on that, to give us pause for reflection here. And certainly templates are a real danger. There's some countries in the world, for example, Germany, don't allow you to use templates. Everything has to be freshly cooked, before you eat it. Eddie Felix.
Two comments. One is just a comment that I think we shouldn't look at the critical view as something that prevents all injuries. It's something that reduces it, and that's important to bring out, whether you're on the defense of the plaintiff. My question is, how do you look at EMR today? EMR produces reams when you look at charts of useless junk. Is EMR good for you or bad, and how should we use it to our benefit, not our detriment?
EMR is a blessing and a curse. I say this as a closet tech geek. The problem with EMR is it provides so much information in so many different ways that the important information gets obscured. And that's a huge problem. In a litigation setting, and that's really where I can address this a little more specifically, in a litigation setting, the challenge is we don't see them in native format. We don't have them on a computer, we have them printed out. And printed out, they're even worse than on the computer. And so it's impossible to find anything. And so if you have an EMR case and you can, use native format, bring your laptop and interact with it in the deposition the way you're used to seeing it. You'll be more comfortable, you'll be able to find what you need. If it's printed out, you're gonna have to spend the time to really look through it and get to know it and learn where the information is you need.
With that, I'm afraid we're going to have to close the session. It's now 9:30, I think, 7:30, 8:30, whatever the time it is, whatever time zone. We thank you for your attendance. Hope we don't see you in court.